Hello friends, Indira Gandhi National Open University welcome you all to this interactive teleconferencing program, and I am Sangeeta Sinha. Friends, this program is jointly conducted by Indira Gandhi National Open University and National Board of Examination. In today's session of teleconferencing program, we are going to discuss on the topic imaging in diffuse in parenchymal lung disease. Before we start, let me introduce to the guest we have with us in our studio. We have Dr. J.C. Suri. Dr. J.C. Suri, Head of the Department, Respiratory Medicine from Safdarjung Hospital. Welcome to the studios, Doctor.
Thank you.
Friends, you can also participate in this program by calling us on these telephone numbers. The phone numbers are 295-328-44, 295-328-45, and we have a toll-free number also, that is 1-800-11-2345. We have a fax number also, that is 011-295-36134. Today's topic is imaging in diffuse in parenchymal lung disease. Dr. Suri, what is this all about?
Thank you. Good evening, ladies and gentlemen. You have just had a very wonderful talk on various histological patterns in diffuse pulmonary lung diseases. If you understand the histopathological patterns of various types of interstitial lung diseases, then understanding radiological feature becomes much easier. As you all know that American Thoracic Society and European Respiratory Society has classified diffuse interstitial lung diseases into 4 major categories, and so is these categories has been basically on the basis of high resolution CT features. As you can see, the role of imaging in the diagnosis of different types of diffuse pulmonary lung diseases. In the first category, you have disorders of known causes, that is those caused by drugs or collagen vascular diseases. The diagnosis is quite obvious clinically. What we have to do with imaging is to basically confirm the diagnosis, to see that the radiological features conforms with the clinical diagnosis, and you also want to rule out any other obvious possible cause for the disease. Now, imaging, particularly HRCT, is very important for differentiating different categories of idiopathic interstitial pneumonias. In fact, HRCT has got a very good correlation with gross histopathological features of these conditions. As far as the role of HRCT and imaging in granulomatous lung disease is concerned, it is quite variable. There are cases with sarcoidosis and hypersensitivity pneumonitis which can be diagnosed clinically, and the role of CT is basically confirmatory. But there is a subtype of granulomatous diseases, particularly in sarcoid, who do not have typical clinical features. In such situation, imaging may play a very important role. And in the last group, where we have heterogeneous group of disorders, HRCT plays a very important role in the diagnosis. Now, what is interstitial lung disease? It has been very clearly elucidated in the pathology class. Interstitium, it is the disease of the interstitium and the surrounding alveoli. Interstitium of the lung is normally not visible even in high resolution CT scan till it becomes diseased by either edema or fibrosis or tumor. Then its volume and attenuation changes, and we are able to see the various components of interstitium. Interstitial space is basically, it is a continuum of loose connective tissue throughout the lung, which basically is composed of 3 subdivisions. The first division is what we call as a bronchovascular, or the axial component of the interstitial tissue, and that usually surrounds the central bronchi arteries and veins of the lung, which usually starts from the root of the lung and then it goes towards the periphery of the lung. The second component is the interstitium, which is around the lung parenchyma, or this is around the alveoli, and is usually situated between the alveolar and the capillary basement membrane. And the third component of the interstitium is subpleural, that is the one which is situated just beneath the pleural lining. So most of the interstitial diseases, when we are trying to see on radiology, then either you will be looking them in the bronchovascular area, in the central area, or you will be seeing it in the interstitium near the parenchymal structure, or you would like to look into the subpleural space and the smallest subdivision, the secondary pulmonary lobule, and in the septas, and the septas which defines these lobules, in those areas you are going to look for the evidence of disease. This is what you can see here. This is the interstitium here between the alveoli and the blood capillary, and it starts from the center, and then the interstitium tissue continues from the center through the various subdivisions of the airways and the blood vessel to the small airways to the alveoli, and then it goes around the interlobular septi. Now, to understand various features, radiological features on CT scan, it is important to understand some basic terminology, and this is what I am going to tell you what we mean by a secondary pulmonary lobule. This is the smallest area of the lung which is surrounded by a fibrous or a connective tissue septa. As you can see here, this is the pleural lining here, and this is the interlobular septi, and in the center we have the small respiratory bronchiole along with the artery, and this supplies the whole of this lobule, which is supplied by 2 to 3 respiratory bronchioles, and the venous blood supply and the lymphatics go along this interlobular septas. So the diseases of the interstitium can involve the subpleural interstitium, the interlobular septas, and if there is a disease of the small airways like respiratory bronchioles and this thing, you will have the involvement at the centrilobular level. There are certain interstitial lung diseases like desquamative interstitial pneumonia, or conditions like alveolar proteinosis. In that you will have accumulation of inflammatory tissue inside the airway space. So in majority of the interstitial lung disease, it is these septas or the central bronchovascular bundles which are involved with these interstitial lung diseases. So this is the CT scan, and here you can see the smallest lung unit or secondary pulmonary lobules here, and all these lobules you can see. Under normal circumstances, they are with a very good high resolution CT scan, you may be able to see these interlobular septi. Now, what are the different ways these interstitial lung diseases presents on X-rays? Now, there are different patterns depending upon the site of the disease involvement. The involvement could be linear, reticular, honeycomb. It can be nodular shadows, as Dr. Sain mentioned to you about certain condition in which you find nodules. Ground glass picture, particularly when there is an airspace involvement. Consolidation, when there is a dense involvement of the airspace and the interstitium. And the cystic shadows, where there is destruction of the lung and dilatation of small airways and the alveolar spaces. Now, this is what I want to tell you here, that these are the linear shadows, as you can see, which are coming from the center. They are also called the curly lines, curly A and the curly B lines, and these are the straight lines you can see which are coming from the periphery of the lung. These are basically thickened interlobular septies, or and these lines are basically thickened central bronchovascular bundles. The second pattern you can see is the crisscross linear shadows, or it is like a a net, what we call as a reticular pattern. So this is the second type of radiological abnormality which we see, and this is more prominent when fibrotic changes are taking place. The third one is the honeycomb pattern, as you can see very clearly delineated here, honeycomb pattern. And then we have the nodular patterns, as you can see in this diagram. The nodules, it's the various conditions where you have granulomas, where you have nodular formation, particularly sarcoidosis, miliary tuberculosis. Then you can have these nodular patterns here, and then you can have combination of these nodules and the thickening of interlobular septas and central bronchovascular bundles, and that is what we call as reticulonodular pattern. So this is what I was trying to mention to you. These are the curly B lines here, which are thickened interlobular septas, which usually contains pulmonary veins and lymphatics. The most common cause of this interlobular septal thickening producing curly A and curly B line is the pulmonary edema, and it can also be caused by infiltration of various inflammatory cells or malignant cells along these septa. These are what we call as the curly A lines here, as you can see, and this is again due to edema of the interstitium in the central bronchovascular bundle. The differential diagnosis of these curly lines, whenever you see in an X-ray both curly A and curly B line, it indicates basically edema, and the common conditions are mitral stenosis, lymphangitis carcinomatosis, there is a infiltration with the malignant cells, malignant lymphoma, congenital lymphangiectasia, idiopathic pulmonary fibrosis, pneumoconiosis, and sarcoidosis. Here you can see here these are the clear-cut linear lines. You can see here curly B lines here, as you can see in this. Here also in the lower right film, as you can see here, you can see these curly A lines, prominent curly A lines. So whenever you see these lines, these straight, these are the thickened interlobular septas very clearly, then you will be able to make out that the interstitium is either edematous or thickened. Reticular pattern, as I mentioned to you, is basically it is like a mesh, it is like a net, and there is a crisscross linear lines. It is basically defined as a meshed or in the form of a network. Reticular opacities can be described as fine, medium, or coarse as the width of these opacities increases. A classic reticular pattern is seen with pulmonary fibrosis, in which multiple curvilinear opacities form small cystic spaces along the pleural margins and lung bases. So you can see here on these two films, one is X-ray chest. You can see this reticular pattern here, crisscross reticular pattern is more easily delineated on a CT scan here. This is very nicely delineated on this. This is a case with the usual interstitial pneumonia, and you can see a very fine reticular pattern of these linear opacity, these opacities in the subpleural area. Now this is the what we call classical honeycomb pattern. Again, advanced fibrosis seen in a patient with collagen vascular disorder due to rheumatoid arthritis, and you can see here the multiple cystic shadows in the form of a honeycomb. This is another situation in which the it is still a more advanced condition of honeycomb, where the cystic spaces have become much bigger and their intervening septas have lost their identity. This is another case. You can see here a very well delineated honeycomb pattern in the subpleural area. You can see that it is bilaterally symmetrical, it is basal, it is subpleural, and typical feature of UIP. Again, another situation, you have gross honeycombing involving the subpleural areas, and in between also you can see in these cases. You'll see the another important thing is that there is very little ground glass opacification or consolidation, indicating involvement of the interstitium, and there is no air space involvement in these cases. Next pattern of radiological shadows we see is the nodular pattern, which consists of multiple round opacities, generally ranging in diameter from 1 millimeter to 1 centimeter. Nodular opacities may be described as miliary if the size is between 1 to 2 millimeter in size, small, medium or large as the diameter of the opacities increases. This is what you can see here. You can see these multiple nodules on both sides. They are scattered, they are sparse as seen in a patient of histoplasmosis. This is another case where a patient with the hematogenous metastasis, and you can see that both the lung fields are uniformly studded with multiple nodular shadows. There is very little linear or reticulation in this situation. Again, you see that in this picture you can see that there are multiple nodules. The important thing here in this nodule is that they are present in the center of this secondary pulmonary lobule. So once you find these central nodules in these lobules, that indicates that the disease is around the small airways. It is probably a bronchiolar disease. Now this is a situation where you can see that there is a diffuse nodules which are present all over the lung fields, not sparing any areas, and this kind of pattern is commonly seen in patients with miliary sarcoidosis or miliary tuberculosis. So once you see a nodular pattern, what are the differential diagnoses which you can think of? They are sarcoidosis, histiocytosis, hypersensitivity pneumonitis, more or centrilobular type, rheumatoid arthritis, and infections with intracellular parasites like mycobacterium, fungal, viruses, metastasis, microlithasis, and pneumoconiosis. Then there is a situation in which you can have both involvement of the interlobular septas, bronchovascular bundles, and also accumulation of granulomas. So you have a combination of both reticular shadows as well as nodular shadows. We call it reticulonodular pattern. You can see here, you can see that there are prominent interlobular septas here, and along with this you will see the periseptal nodular shadows. So this is what we see as reticular nodular shadows, particularly in patients with lymphangitis carcinomatosis. There is another case with the disseminated histoplasmosis, and you can see here both lung fields are studded with nodular shadows, and you can also see that interlobular septas are thickened. So this is a typical pattern, what we call as reticulonodular pattern. Then we come to the next category of radiological shadows which we see, and that is what we call as ground glass appearance. Now this ground glass appearance, you can see here that these are shadows, these are opacities which are not that dense. So you can still see the blood vessels through them, but the blood vessels outlines are attenuated, but you can still make out these blood vessels. If you don't see these blood vessels through these opacities, then we call it as consolidation. Now these shadows are commonly seen in conditions where there is alveolar filling with inflammatory cells. And here the last category, the next category is consolidation. Here you can see that you are not able to see the blood vessels between this, and this is what we call a typical peripheral consolidation with the presence of central air bronchogram. These bronchi containing air can be easily seen in this. This type of presentation is seen in various infections like pneumonias, organizing pneumonias, and other inflammatory conditions. The last category of radiological shadows which we see are the cysts, And the cysts can be of varying size, various shapes. They may be diffuse, they may be uniform, there may be associated nodules along with this, or they may be without nodules. So you can see here one of the case of eosinophilic granuloma. So you can see multiple cystic shadows. There another condition in which you can see that there are multiple nodules of varying size. There is a coalescence of these cysts, and there is absence of nodules in between. These are typically seen in lymphangioliomyomatosis. So we have now different patterns of radiological presentations in interstitial lung disease. Each depict a typical type of underlying histopathology. Now we have two types of imaging modalities. One is the X-ray chest and the other is the CT scan. Now X-ray chest is also routinely used as an important investigation in the evaluation of diffuse pulmonary lung disease, although it has a lot of limitation, because in about 10 to 15% of symptomatic patients it may be normal, and even if when we see some abnormality in the X-ray, it may be too non-specific to give any information regarding the etiology of the underlying disease. It can also result into various patterns which can mimic different conditions like paraseptal emphysema, small airway disease, and it may be difficult to differentiate. The overall sensitivity and specificity of this modality is something to the tune of 80 to 82% respectively. The confident diagnosis can be made by experience in 23% of these cases, which are later on proved to be correct on histopathology in 77% of cases. Now, although X-ray chest is not very sensitive, it does not give us a very good clue about the underlying etiology of interstitial lung disease. But still, there are certain important features in the X-ray which can help us to at least make important differential diagnosis. Now this is basically on the basis of the distribution of the disease, whether there is an involvement of a particular zone like upper zone, middle zone or lower zone, or whether it is associated with mediastinal lymph nodes or the presence of pleural effusion or other condition. Now you can see if on an X-ray, if the disease is mainly involving the upper zones, then it may be associated with sarcoidosis, eosinophilic granuloma, cystic fibrosis, silicosis, ankylosing spondylosis. On the other hand, a disease which is predominantly involving the lower zones, the peripheral zones, the important differential diagnosis will be IPF, ILD associated with collagen vascular diseases and asbestosis. There are conditions which are associated with lymph nodes in the mediastinum. The important diagnosis is silicosis and sarcoidosis, and we have already talked about the linear shadows, both in the form of curly A lines and B lines. They are associated with various conditions like pulmonary edema, mitral stenosis, lymphangitis, carcinomatosis. Fleeting shadows, the shadows which are coming and going into the different regions of the chest over a period of time, may indicate cryptogenic organizing pneumonia, ABPA, and Loeffler's pneumonia. Cystic shadows, although little difficult to appreciate on X-ray chest, if you can do, then it is highly suggestive of heterogeneous disorders like lymphangioliomyomatosis and eosinophilic granuloma. So you can see here, this is a patient with idiopathic pulmonary fibrosis. The X-ray shows reticular shadows basically involving both the lungs. Overall, the volume of the lung is reduced, and you may be able to appreciate in some areas some degree of honeycombing. This is another X-ray which shows